Thank you for joining us in our October webinar, Winter is Coming, Assessing COVID Risk for Indoor Settings. Our special panelist today is Judy Kauerauf from the Illinois Department of Public Health. She received her Bachelor of Science degree from Northern Illinois in Community Health and her Master's of Public Health from the University of Illinois. She began her career in 1988 as a disease investigator for the Will County Health Department in Joliet, Illinois, and she began working for the IDPH in the HIV/AIDS section in 1989 as a surveillance specialist. In 1994, she began working in AIDS prevention, ending her tenure with the AIDS section as the state's prevention administrator. After a short sabbatical following the birth of her triplets, Ms. Kauerauf returned to State Health Department in 2002 to direct the department's implementation of its electronic disease surveillance system, and in 2007, the Illinois National Electronic Disease Surveillance System received the HIMSS Davies Award for Excellence in Public Health. Thank you so much for joining us and enlightening us a little bit on how we can make better choices or more informed choices as we participate in activities throughout the fall and the winter. If you're ready, the floor is yours, Ms. Kauerauf.
Yeah, and I do believe I sent you an old CV, but since 2016, I've been in my dream job here at IDPH as Communicable Disease Section Chief and have been part of the COVID pandemic since then. I was actually on site at St. Alexius Hospital with the first Illinois case and began our investigation of COVID with that first case, which is now where we are today with a situation. So I'd like today to first give you a situational update, kind of let you know where we are with COVID in the state, how things are trending, show you where you can go to look at data, not just for the state, but for the county, so that you see where COVID is going and where it's going in terms of positivity rates and case rates, as well as our flu data and other respiratory viruses. And then talk specifically about what you can do to protect yourself and your loved ones from infection and being able to enjoy yourselves this winter, but also do that as safely as possible. So let's go ahead and pull up the PowerPoint and we can get started. All right. Okay. Let's go ahead and go to, there we go. Okay, so this is one of the slides you'll find on our COVID landing page at IDPH, and this gives a look of where we are statewide. And we think of COVID nationally as being in low transmission, moderate, substantial, and high. And you all may remember back at the beginning of the summer where things were all blue and things were looking really great. We were very optimistic that we were at the tail end of this with vaccines being available to everyone. We felt like we were very close. And I think much of this the history will be yet to be told of how close we were. But then Delta hit, and I'll talk a little bit more about that. But we are currently statewide, except for a very few counties, and we sometimes think that has to do with under testing there, but still in high transmission statewide. So next slide. This is actually just launched this week, a new website. Our new website, it's not necessarily, other than being rebranded, the information remains pretty consistent with what we've been putting out. We continually try to make as much data available to you as we can. We feel like that's our responsibility. We collect a lot of data. This is by far the biggest amount of data we've ever collected on any particular condition. Previously, hepatitis C was our main disease that had high volume, and that was 15,000 cases annually. So to be dealing with a disease that has nearly 1,700,000 cases is astronomical for us as a state to be collecting all these data. But we are doing our best to make those data available to you. So you always find on the landing page the total number of cases, and I'll go through some of this in more detail. But if you look on the left, you'll see all the different elements of data that you can access in terms of data on some of our outbreaks, and I'll show some of that a little bit more going forward. Next slide. So this really looks at our 4 waves as they've been referred to. So we started out with the first spring of 2020, where we were pretty much locked down. So we were able to contain and flatten the curve, as the verbiage was at that time, our initial spread of COVID. And most of our work and our outbreaks were in long-term care facilities. We were doing everything we could to keep that very vulnerable population safe. And then we did well again in that summer, and knew we were in for a seasonal tick like we would see for flu. People would be going indoors. And I really saw us pick up when college went back into session. I remember late August hearing lots of reports of cases on college campuses. And I'll show you later that 20 to 29-year-olds have been the age group that has been really leading in transmission statewide in most of our peaks. And I think that's a story I want to leave you with, is that the young folks will most likely not have severe disease, but they contribute greatly to the spread to those that are more vulnerable. And so in the fall, going into the holiday season, about right where we are today, we saw things turn upward, and they remained at high levels for the entire winter period. And then enter in late December our vaccine, and we were able to get doses of vaccine in our most vulnerable first, our essential workers, our healthcare workers, and then to the general public. And you can tell that then in future waves, our numbers are not as high, but in this 4th wave, we like to call this the wave of the unvaccinated, that are most of the cases we saw in this 4th wave. Next slide. And as I made the point earlier, we are seeing the 20 to 29-year-olds. If I were to have put a frozen my image on this highest peak there, you'd see that 20 to 29-year-olds made up the most cases during that first wave, or our largest wave. And so you can also, this map or this graph is interactive, and you can go to any of the peaks and look at the similar kind of pop out I have there for the age categories. But concerning to us going into school, and I'll talk a little bit more about what happened there, was a younger population. And so our biggest peak in our 4th wave, which we generally refer to as our Delta wave, were in those less than 20. And prior to this Delta wave, we didn't see a lot of transmission in young kids, especially those that were less than 12. But certainly that's where we were seeing it. And some of that has to do with the fact that they are mostly the young adolescents are not able to have vaccine yet. So next slide. So this is a look at age and demographics over time. And as I said, generally the 20 to 29-year-olds have led the pandemic here in Illinois, with being challenged by those over 20 more recently. And if you hit the next slide, and I'm going to go through these really fast, and I encourage you to go ahead and take a look at these. This is kind of where I made the point of, let's not just think of this as a pandemic of the elderly, but clearly those who are older have a higher risk for severe disease and death. So this is actually filtered on deaths. You have all these 3 tabs when you're in this graph to look at all 3 of them by, this is looking at by age group as well as race. So a couple of things here. You can definitely see that those that are older have the higher risk and of severe disease and ultimately death here. But certainly they're not the ones getting infected the most. And so that is, our challenge with this pandemic is those that are young feel very healthy, feel like they could survive COVID. But I think the thing that we try to have people understand is that that you may, but you also may transmit it to someone else who may not have a good outcome. I love how my son talks to his friends about this. And he says, I didn't get vaccinated just for myself. I would have hate to think that I could pass it on to someone else. And so that is how this pandemic has unfolded in terms of the age groupings. Next slide, please. And this is just released this week. It's our new website on youth. And it is interesting to look at our youth and how the 7-day, what you're seeing here is a view of the 7-day rolling average, which we do to kind of flatten out bumps that may happen daily. We generally see more testing on Mondays than over the weekend, and it can bump things up. So the 7-day rolling average can smooth things out. But if you look at the older 18 to 22-year-olds in the youth category, had led pretty much the whole pandemic until we hit the summer. And I'd like to think that's got a lot to do with vaccine here. But we are seeing an uptake in younger kids, 0 to 4 being the blue line, 5 to 11, and then 12 to 17. So this is concerning if you think about the mobility of children. They really don't go a whole lot of places like you would expect an older young adult or a teenager who might be at work and playing sports. And so what we also saw with Delta is more transmission in this age group. And this is a very successful virus. It competes to stay alive. It finds dead ends with vaccinated populations. And so it's making its way to the unvaccinated population, which is younger kids. We also look at data by emergency department visits. And I'll talk a little bit more about other respiratory viruses that are circulating, but certainly for young kiddos, we are seeing an uptake in respiratory disease. And in particular RSV, and then COVID winning out in emergency department visits for those 5 to 17. And so you hear a lot that kids don't get severe illness, but we certainly do monitor and see a percentage of our ED visits of young, healthy kids coming in with COVID. Next slide. So I like to, I don't know if this will be something others say, but I feel like we have a tale of two pandemics. I work a lot with schools, and school year last year was so different than school year this year because Delta has, it almost feels like a new virus. So I want to unpack that just a little bit more for you to understand how Delta has really changed things for our response. So this is a look at a cumulative report over time. Hey, Alex, I was missing the slide on the US deaths from other pandemics. That would just go too fast and not see that one? Okay, that's fine. It may just get bumped out, but I did want to, I think I'm also intertwining within here what I hear about as myths or misinformation about COVID that I'm going to try to weave in here to clarify some things that you may have heard that aren't really accurate. And I was having a conversation with a citizen that called the state health department and wanted to talk to us about our COVID response. And we're always happy to listen and hear how folks think we're doing with the response. But, you know, I went through a lot of things that she wasn't aware of. And she said, you guys need to be telling people more about this. And we do. But I thought I'd be remiss if I didn't do due diligence to spread some of that in here. But I hear a lot that COVID is just like flu. And recently, I think it was Johns Hopkins that put out some numbers of death from other pandemics. And to date, COVID is leading of all pandemics in terms of the number of deaths. At this point, we're nearly at 800,000 deaths for about an 18-month period. Compare that to the 1918 flu pandemic, where over more than 2 years, there were 675,000 deaths. And you know, the thing that differs a lot from that experience is that we had a less mobile population society, that there were just less people as well. And then HIV/AIDS, which is we've had with us for 40 years now, has had a total of 700,000 deaths. The H1N1 pandemic, if we look at H1N1 as a virus from 2009 to 2018, there have only been 75,000 deaths. And endemic flu, annually, we only have in the US 36,000 deaths. So flu and COVID are not similar whatsoever. We see much more severe illness with COVID, much higher death rates than we do with seasonal flu. And I'll talk a little bit more about transmissibility too going forward. All right, let's go ahead and move on to the next slide. So we have in epidemiology, we think about a factor called the R naught, and it's really just the transmission rate. And so the original stand had an R naught of about 2 to 3. And so a person would be thought to infect 2 other people. When Delta came on the scene, we started seeing a lot more transmission. And I'll talk about my first Delta outbreak and how I knew it was Delta right off the bat by the number of positives we had in a particular camp outbreak. But Delta now has an R naught of between 5 to 6. So that means a person will infect 5 to 6 people. Measles, which is one of our most infectious disease that thankfully we have good vaccine coverage on, but measles is always thought of as one of our highest infections, and it has an R naught of between 12 to 18. So, we hear a lot about herd immunity, and R naught isn't a factor of how we think about herd immunity. And with the early strains of COVID, and when we talk about Delta, I should probably take a step back, and I really didn't talk about how we sequence viruses, and we do this with all of our viruses. We do this with some of our bacteria as well, and it's how we identify and know whether they're the same, close to being the same strain that's circulating that might be impacting people. It helps us define outbreaks. With COVID, it's significant because we look at transmissibility, we look at how well the vaccine is covering this particular strain, as well as how treatments, monoclonal antibodies and other treatments are also able to be neutralize this particular virus and prevent severe disease. And so we're continually sequencing our viruses here in the state. And actually through our partnership with SIU in Carbondale, we've been sequencing since January of 2020. So it's not a new thing for us, but more recently we've been talking about variants of concern. And these are ones that for either being more transmissible or having some issues with vaccine or with treatment are concerning to CDC. And so we're monitoring them more closely. So next slide. The other thing that we know about Delta and that did change, and I alluded to this earlier, is that we saw children becoming infected at higher levels than we had seen before. We are seeing hospitalizations increasing at 10% for the 0 to 4, or 10 times an increase from the previous strains. And then for unvaccinated adolescents, we're seeing them being hospitalized 10 times higher than those that are fully vaccinated. So this is based on a study that CDC did with hospitals and children between March and August of 2021. So next slide. And so this was my first experience with a Delta outbreak. So it was the day before I was leaving for my first vacation in several years. Right, like the half hour before I was leaving, I got a call from a local health department saying, I've got a camp outbreak. I've got 54 kids positive, which we had not had outbreaks at that number that fast ever. And there were about a total of 400 kids at that whole camp, kids and staff together. So that attack rate was much higher than anything we'd ever seen with prior strains of COVID. I mean, we'd certainly had outbreaks of larger numbers and those grew over time, but to start out with a camp that had just started, and I think they had only been in camp 4 days. So Delta had, the virus had spread that quickly among those campers. And so it told us a lot about Delta. And it informed a lot of where we went with school guidance this current year, just experiencing Delta with this camp outbreak. We invited CDC to come in, and they brought an epi team to look at this as well, because we not only wanted to look at how it spread in that camp and what mitigation measures were missing that it led to that spread, but it also showed us how in a young population, an adolescent population, it spread into the community and really it started one of our earliest counties in the exponential growth with COVID that we saw in this Delta wave, or this fourth wave. So what you're looking at there is a map, or is this graph. The blue represent the outbreaks in the camp. So these were just campers that were exposed and developed disease during that camp experience. And so there were a total of 122 cases of, so there was about a 25% attack rate overall that, like I said, we weren't seeing with other strains. And 85% of those that were infected were not fully vaccinated. 18 were, which this was also our first experience with an outbreak of vaccinated persons who got infected. And that was troubling to us as well. We know that the vaccines are not 100%. This is a very good vaccine at 95% against the earlier virus. But with 18 fully vaccinated, that also became concerning to us. And what we've learned about Delta is the vaccines are still really good against Delta. We do see transmission so they're not as effective as decreasing infection as they were for the other. It's still very, very high. It still continues to be very high in terms of preventing severe disease and hospitalizations and deaths. And I'll show more on that later. But what this also showed us, if you look in the purple, there was also a men's conference that were secondary cases to the camp. And then the gray are community cases. And so it shows how a population where COVID spread and how it went into secondary cases and then really ignited the outbreak in that community and really accelerated our transmission statewide. And so the other thing that we learned is that masks were not worn, testing was not performed. So none of the mitigation measures that we strongly encourage and our camp guidance had asked for were implemented. And so going into school and knowing where Delta was going, we knew we had to have masks on or we would see rapid transmission in the schools. And in schools that were not using masks early on, we certainly saw greater levels of transmission and outbreaks than in schools that were adopting universal masking. So next slide. I did want to talk a little bit about other respiratory viruses because I think this is important to understand as well. There's that other slide. So we can move on. We also this spring started to see an uptick of other respiratory viruses. It really started, we had an outbreak in a long-term care facility that they were testing negative for COVID. So my first thoughts went to Legionella because we did have some pneumonia that was ruled out. And so we did a viral respiratory panel, and it was parainfluenza A, which we had been seeing, parainfluenza virus, which we had been seeing in other long-term care outbreaks. So we started seeing that. We started seeing RSV in children, which we hadn't seen at all last year. So we've seen that increase. And the normal coronavirus, which we generally think of as a common cold, we started to see an uptake in that as well. So in addition to concerns of going into the winter with COVID, we're also seeing other respiratory viruses ticking up as well. And so next slide, please. CDC presented on this recently, and so I've bootlegged a few of their slides. I do reference them or source them at the bottom. But this is a normal flu surveillance that we do. It looks at not just flu, but pneumonia, which generally is from a respiratory etiology, and then COVID. And you can clearly see these are our seasonal flu data over time. And so it's just a blimp compared to what we saw with COVID in 2020 and 2021. Again, making the point that this is not flu. This is not just like flu. These are percentage of deaths due to pneumonia, influenza, and now COVID being added to this as a surveillance tool going forward. Next slide. And for you to be aware of COVID versus flu, any of those that have children you in school, you know that if they develop any level of symptom during the school day, we're going to ask that they be tested for COVID. And there really is, the symptoms of COVID are the symptoms of every other respiratory illness, can be the symptoms of asthma. And so we know it creates a difficult situation for parents to have to get their children tested if they have any of these symptoms. But we also know from experience that these are the symptoms of COVID. And every single outbreak, many outbreaks that we have, it starts out with, I thought it was asthma. I kept coming to school or I kept coming to work. And then I found out, oh, so-and-so had COVID. So I got tested and turned out it was COVID. And so we know that COVID can be disguised as many other common illnesses. We've had co-infection. I always tell the story of my son who came home Thanksgiving, hadn't seen him in 4 months, positive with influenza A. I had him tested for COVID because he had exposures and he also had COVID. So you can have co-infection as well. That's why we don't allow an alternative diagnosis to allow a child back into school. We also want to see them tested for COVID. But fever, cough, body aches, tiredness, those are both flu and COVID, as well as without the fever for like a common cold. But loss of taste and smell is generally what we think of as a hallmark symptom for COVID. So if you have loss of taste and smell, likely it's COVID and you should be tested. You should be tested. And that's the thing, I think the thing I want you to think about going into winter is that there are other viruses that'll be circulating, but it could also be COVID. So please test. And I'll talk about that more in a minute. We think a runny nose and sore throat are not as likely, but we see a lot of people that's the only symptom they had is congestion. We see people just have a sore throat. So even though they're considered minor for COVID, it could definitely be COVID. And then severity, it does vary with COVID. I think the thing that we've also seen, because we've seen death in people that you would thought have been healthy, people have underlying conditions that haven't been diagnosed. Just this past week, I think we had 6 or 7 deaths in 30-year-olds, all unvaccinated. So severity is mostly thought to be in older adults, but also in individuals that have underlying conditions. So severity is definitely across all ages. Where with flu, it varies. Young children and older adults tend to have worse presentations with flu. But again, if you go back to my data on flu deaths, certainly not on the same level as we see in COVID. The other thing that really makes COVID much more transmissible, in addition to its R0, is that you're infectious for longer periods of time. COVID can be from 2 to 14 days. That's why you quarantine for 14 days, because you could be infectious after an exposure for up to 14 days. Flu is much shorter. You're only going to be infectious for 1 to 4 days. The other thing that makes COVID concerning is when you are infectious 2 days before you develop symptoms. So if you're not infectious and you're feeling good, you're going to be walking around, you're going to be going places, you're going to the gym maybe, you're maybe not masking because you think you're healthy and you're not worried you're going to be transmitting it to a loved one or to anyone that you encounter. But if you had an exposure, you could be infectious and you may not develop symptoms for 2 days, but you're infectious for those first 2 days. Next slide. I just wanted to point this out. This is our flu report that you can find on our website, like you find the other data where we monitor flu cases, hospitalizations, ICU admissions, and outbreaks. So you can keep tabs on that as well as COVID from our website. Next slide. And this is just another, some of the data that we put out on testing that's performed. And this is another question I had in that conversation with the caller a couple of weeks ago that I get frequently, is that the test, you can't tell from the test whether it's flu or COVID or what kind of coronavirus it is. And absolutely we can. We have amazing technology. We have rapid tests, we have home tests. They all are sensitive and specific for SARS-CoV-2. They are going to test only for that. We are going into flu season now. We are we are testing, and tests are coming in the clinical arena as well, but our surveillance testing that's being performed for influenza is also going to be testing for COVID. It's called a multiplex test. And we're encouraging healthcare clinics to also be adopting that. So they're testing with one swab for both flu and COVID. But we absolutely can tell diagnostically when testing that it definitely is SARS and not flu, and not another, it's not the common cold. We are very much, with our testing technology, able to differentiate between SARS, human coronavirus 3, and influenza. And then even with our influenza surveillance, we subtype those between A and B, and then further on down to know what H and N level of etiology that particular strain of the virus has. So just want you all to be very clear that the science and the testing technology with SARS-CoV-2, with flu, are very sophisticated, next, and robust. Next slide. So CDC did on a presentation last week to the Infectious Disease Society, address flu and why we think activity was so low. And you all probably have had these same thoughts. We were all physical distancing, we were staying home, everybody was wearing masks. Everybody's, for the first time, realized it's important to wash your hands. So that's great. Hopefully that behavior will continue. Schools were closed, and we were improving indoor air ventilation. So the argument I hear to that a lot is, well, if we were able, if flu was there and these things worked, why didn't they work for COVID? You got to understand that COVID was already here going into winter. And so it had already got a foothold in. We didn't have vaccines, whereas flu, we have vaccines. And so we had a vulnerable population, and it was already prevalent. You had people already infected that were spreading it, where flu didn't ever get a foothold. It has to find a susceptible host. And these mitigation measures were working for flu because it hadn't yet been introduced to spread. Next slide. But probably a couple of things you hadn't thought about that CDC is saying. One of the things we monitor is flu activity in the other parts of the world, where their past flu season is a little bit low, but we're not anticipating that trending is necessarily going to equate to what we will see. The population may be a bit immunity for flu down a little bit because we had such good protection in the past year, especially among young children who don't have a lot of natural immunity from past exposures. So they could see higher levels in that population, which makes it even more important for kids to get vaccinated against flu. And then what we're also seeing is just a wariness in the population. They are, whereas last year, folks were on board with what we were trying to do. This year, people in general are becoming weary of the metrics or the things to do to prevent COVID, which also prevents flu. And we hope to convince folks that we need to stay diligent on those things to protect ourselves, not just from flu or from COVID, but also other respiratory viruses. Next slide. So let's talk about what you can do to protect yourself. And I usually think of these as mitigation strategies. We want you to have no risk. And so I think of these really more so as a preventative things that you can do. So let's dig into those a bit. So this is I talked already about a camp outbreak that went wrong. This is about a camp experience that did everything right and it works. So this was 7,000 people that attended 9 overnight camps. And they had layered mitigation. You might have heard, we talk about it as Swiss cheese, where we fill all the holes. But it's really about multiple strategies that you can use to keep yourself safe. We had, in this population, 93% of people were vaccinated. They did all layers of mitigation that I'll unpack a little bit. They were testing, they were isolating, quarantine, they were keeping physical distancing, they were masking, doing good hand hygiene, and they were keeping their groups small. And so that whole entire experience, they only had 9 people that tested positive. Most of those people were positive coming in, and there was no evidence of transmission at that camp. So this shows that these layered mitigations do work and keep people safe, and they had a camp experience. So you can have your normal experience or your normal livelihood, it's using all levels of protection to keep it as safe as possible. Next slide. So of course, I'm going to start off with vaccine. Vaccine is absolutely our best protection. I'll show a data here, but the risk of COVID, the risk of severe COVID is so much more of a risk for everyone than the rare side effects from the vaccine. So not just COVID, but flu vaccine as well. I don't have a slide on it because I don't want to belabor this too much. But I do also hear a lot about deaths from vaccine. And folks point to the Vaccine Adverse Events Registry, VAERS, you may have heard it called. And that is what we refer to as I'm looking for my notes so I don't miss anything. It's a passive surveillance system. So it's not a rigorously documented like we do with our COVID data. Anybody can report. In fact, providers are required to report any death in a person that's vaccinated, even though if it were unrelated to even the doctor thinking that it had anything to do with COVID. I think I brushed over our breakthrough cases, or maybe I have, I do have that coming up. So anytime we have a person that develops COVID that was fully vaccinated, those get reported, or any COVID deaths. But a lot of, if you think about you're vaccinating millions and millions of people, coincidentally, millions and millions of people over time you'll have deaths among the general population. And that's also part of it occurring. It's a coincidental type of a report. And so all of those deaths that get reported to VAERS are not as a result of the vaccine. And this is not meant to be a documented vaccine reaction database. They are monitored by scientists at CDC, and they evaluate them and look for any aberrations in or clustering of particular illnesses that they find resulting after vaccine. And then they'll investigate those very rigorously to determine what actually happened there. So next slide. So we do, this is also on our website where you can look and see how many folks in Illinois have been vaccinated. We are doing really well. If you look at the population 12 and over that have been fully vaccinated, we're at 63.2%, and at 80.7% of people that have had at least one dose. So those are good. In the Midwest, we are leading the pack. We can do better. We really need to see those numbers go up. It is a metric we continue to work on. We're excited to have vaccine available to 5 to 11, likely on November 2nd or 3rd. We anticipate that vaccine being able to get into arms of younger kids. And then let's go into the next slide. I think that's where I have my breakthrough data. No, I'll get to, I think I have another slide on, that's okay. So we do monitor breakthrough cases, and it's very, very small percentage of our total cases. I think so a breakthrough case is someone that was fully vaccinated and developed disease and was hospitalized or died. If you think about it in terms of all the people that are vaccinated, I think it's 0.03% of people that were vaccinated have been hospitalized, and the number of deaths is even lower than that. So it's a vaccine that's 95% effective in particular areas in terms of severity and death. So we do anticipate there will be some breakthrough, but much more disease and deaths occur in the unvaccinated, significantly more. Next slide. And this is just kind of making that same point and looking in terms of hospitalizations in children and adolescents. So in states that have low levels of vaccine, you see 4 times more hospitalizations than in states that have higher levels of vaccine. So it clearly shows even in the younger population, it prevents severe disease. Next slide. And then these are data from CDC as well, a large study that showed that even with Delta, that vaccine is not as effective as it was in the earlier strain, but still a really, really good vaccine. You're 5 times more likely if you're unvaccinated to get infected, greater than 10 times more likely to get hospitalized or to die from COVID in an unvaccinated person. Next slide. And this was just a study that just came out, and tried not to get too study heavy on you. But this just came out in JAMA on Monday, I believe it was. And it looked at infections in families, and looked at, based it on how many members of the family have been vaccinated. And so there was an inverse dose response association. So essentially, the more people in the family that were vaccinated, the less likely it was that there be transmission. And we know household transmission is really efficient, but when there was a 75 to 86% reduction in infection with just 2 immune people, with 4 immune people, it went up to 97% of a reduction in infection, which is almost perfect. So it definitely showed in a household where transmission is, we see the most transmission of how vaccine protected family members. Next slide. And this is maybe a little bit more science than you want to see, but if you love science, hopefully you'll appreciate this slide. When I talk to schools, I always encourage, I hope science classes, I hope university-based school or a microbiology class is using this to study and understand the immune system, because I think it's much more tangible to students now as they're living through a pandemic. But this study looked to show the difference between the immune response from vaccine and how it protects against infection versus how it is able to limit the number of hospitalizations and death, which is the real power of this vaccine. And it appears that the CD8 and the memory cells, as part of that immune response, are the reason why we're seeing this consistent, even with Delta, and that's what it's looking at here, the consistency in the decrease in hospitalizations and death, even with the mutation to Delta. It's with that immune response and that memory, especially that memory cells that prevent severe disease. It's an NIH study if you ever want to read into it a bit more. Next slide. There's my vaccine breakthrough. So yeah, I do want to show this is 0.03% of hospitalizations, and this is statewide since January. Of all cases, a little over 2,000 have been hospitalized, and we've had 617 deaths in fully vaccinated persons. And if you look at the bottom there, and this is another piece of data you can find on our website, many of them had an underlying medical condition or an immunocompromising condition, which we are finding has the immune response from vaccine isn't as good, and that's why you've seen the booster doses that are coming out to give that extra boost to individuals that have a compromised immune system or other underlying medical conditions, to give them a bit more protection to prevent breakthroughs. Next slide. So the next thing you can do is mask, and I'll show you in a bit some of the research on mask. Masks absolutely do work when worn consistently and correctly. CDC has a website of how to wear them correctly and how not to wear them. I think we've all learned over time how it is correctly, covering the nose, well-fitting around so it makes a nice seal around the face. And next slide. We definitely have seen, and CDC's research and our own, transmission, and how transmission is either higher or lower depending on whether the school is having mandatory masks. This was a study in Arizona in the 2 largest school districts, and it showed where masks were mandated that they were seeing less outbreaks. Where there was no mask mandate, they had 3.5 times more outbreaks than the schools that were masking. And I see this every day. I monitor school outbreaks. I'm certainly seeing cases and outbreaks. And sadly, I'm also seeing secondary cases in family members where there's severe outcomes from outbreaks in school. And so I think that's the point I hope you walk away with, is that even in schools where we don't expect children to have severe disease, but children go home to families and we've seen secondary transmissions in families there. Next slide. This is just another study that was recently done on masking, this was CDC looking at national data on masking. It was actually a really well-developed study where they looked at websites and scoured those data and found marginalized or randomized the data out so that it didn't. You're really not looking at a time factor here, but you're looking at cases in a community before school started to when school was in session going out. And you can see the increase in cases as schools started without masks. The blue lines are those schools that had no mask mandate, with the light shaded ones being those that did. Next slide. I think the thing I hear most about masking is that masks aren't safe, that masks cause health issues, that a number of different arguments that masks aren't safe. And so this is a scientific brief that CDC has had out since May, where they provided references to over 50 or 45, I believe it is, different studies on mask and mask safety. And it showing no significant adverse health effects for those that are wearers of masks. Hopefully I've shown you enough data that they are effective in preventing COVID and flu and other respiratory bugs. And CDC had announced a couple weeks ago that they were going to be updating this. It's as of yesterday, it hasn't been updated, but they've expanded their research and looked more specifically in children and continue to see no evidence of physiological problems due to masking. But I'm looking forward to them to update that so that there's more support there for you. Next slide. And then the one that gets cited to me the most is a JAMA just editorial, I believe it was, earlier in June, that was since retracted by JAMA due to the flawed nature of the study a couple weeks later. This was one looking at some carbon dioxide in masking in children. It was debunked or was found the research to be flawed and was retracted by JAMA just a couple weeks after it went out. So a lot of times you'll hear about this study, but once the word's out, it's hard to rein it back in, and for people to know that this study has been retracted from JAMA. Next slide. Testing and monitoring. So let's talk a little bit about that. This is a person doing a saliva test with likely Shield, which is an excellent test that we hear and use in Illinois. In many of our schools, we've found great success with it. It's the interesting thing about it, you always hear about nasal pharyngeal swabs being the gold standard, but what's so great about the Shield test, especially in schools, is that it's able to detect in that early pre-symptomatic stage when people don't develop symptoms yet. And so that's really what makes it so powerful in our schools where they're doing screening. So when should you test? Of course, when you have symptoms, and hopefully I showed you in that slide already, regardless of the symptoms. If it could be COVID, let's get tested. Let's stay home and not be around other people until you know you're negative. Anytime you have a fever, stay home for at least 24 hours after your fever. Diarrhea and vomiting, at least 24 hours. If you're working in a sensitive occupation, we prefer you to be out for 48 hours. Those infection virus from some of those can still be with you even after your symptoms have been gone. And so in general, if you stay home and you won't spread any diseases. When you've known you've had an exposure to someone with COVID, or if you've been at an event or where you've heard people are positive for COVID, you should be tested. If you're unvaccinated, 5 to 7 days after that exposure. I like to tell people, get tested right away, because there could have been somebody at that event that you were at, that other person was at, that already was infected. So you may have been at the same place where somebody else got infected. So test right away, and then 5 to 7 days after the exposure, but definitely 5 to 7 days after exposure. You should be in quarantine anyway. But the sooner you know that you're infected, the sooner you can protect yourself protect others, and then also be monitoring yourself for symptoms. If you've been linked to an outbreak, and it's recommended by your health department, or you get knowledge that, there's an outbreak at my son's daycare, he wasn't identified as a close contact, but I would still recommend testing again at 5 to 7 days out. And then screening. If you work in a high-risk occupation, if you live in a congregate setting, or attend university, or other locations like in schools. If you have a child in school, we really do encourage you to sign up for screening. It's the one tool we have to keep schools open. The sooner we can identify a positive in the school, the quicker we can avoid any transmission. So that screening testing helps us keep schools open. And then after you've traveled, especially if it's been to high-risk exposure, CDC recommends if you're unvaccinated that you be tested, that you quarantine and then be tested 3 to 5 days after returning. Next slide. This is another slide to show you, and this actually shows the power of shield testing. At the bottom is that saliva test. I really want to point out, if you've ever had an antigen test, which antigen tests are great in that they're rapidly available. You can get results right away. Our schools are using antigen tests to test right on site. So if they have a child that's sick, they can give them an antigen test. And if it's not a symptom that they need to be excluded for and they test negative, they can stay in school. But one of our concerns in someone that might have had a known exposure is that as time goes on, that the antigen test is not as able to pick up and test positive, wherein a PCR remains able to detect for a longer period of time, as does the saliva, the shield test, which is a PCR test as well. Next slide. What other things that you can do, and this, it looks more at the physical distancing. I think I lost my physical distancing, but we like to use the word physical distancing because you can still be social with things like Zoom meetings, but physically to keep yourself separated from others. So avoid crowded locations, indoors and outs. I went to a fall festival. It was outdoors, but it was super crowded. And I had my unvaccinated godson with me. So we went and picked our apples, but we kind of avoided the more crowded locations. So it's always good to assess the situation, and you can still have fun, find ways to do that, but make sure, even if you're outdoors, to stay away from really crowded locations. If you're sick, I mean, we never did this, but why not? Why did we not when we were, I always think about when anybody in my household growing up was sick with the flu, they laid on the couch in front of everybody and coughed and hacked all over the place and likely infected the rest of the household. So when you're sick, stay away from your family, hold up in your room, have people wait on you, and just get tested in that situation as well. But try to distance yourself if you have any level of symptoms until you know you're negative or what it is. With the holidays approaching, try to keep your gatherings small. And we're not telling people not to get together with family, but try to keep things small. Think about the room, make sure it's large. Get vaccinated. I was not real popular with my family. We made plans to get together over Labor Day. And I made people, if they weren't vaccinated, which is another subject, they had to test before they could come, because I wanted to protect my mom and dad. And so it should be socially acceptable for you to ask about people being vaccinated and to require testing to attend your event, especially if you have older people that will be there that you can protect. And you still want to social distance, you still want to have masking, but we want to be able to gather as families over the holiday season and do that as safe as you can. And then avoid crowds in poorly ventilated spaces, restaurants, bars, fitness centers, movie theaters, and always mask in those situations. Try to do, if you do go to a health club, try to do as many classes outdoors as you can. Really avoided a crowded bar with no ventilation. Hopefully we can be outside as much as we can. I love to eat outdoors. I love to hang out outdoors with my people. As much of that as you can continue to do, even as it gets cold. Actually, I was just listening to a podcast about how fresh air is so good for us on so many levels, even with your whole outlook on life when you're outdoors more. It helps with some of that, the indoor seasonal depression syndrome some people can get, is just to be outside as much as you can. Next slide. Generally in terms of COVID, if you're you need to isolate for 10 days. If you have COVID, quarantine, it can be kind of confusing. We try to offer some options so that it is our goal to quarantine people as minimally as we have to. And so if you're a household contact and you've had a pretty good exposure, we're going to recommend 14 days. But if it were a brief exposure, I encourage our health departments to be using 10 days and 7 days with a negative test, especially if masks were used in that type of an exposure. We're really doing everything we can to keep kids in school. We know schools where masks are present are safe places. We want to get kids caught up on any learning that was lost last year. So we're doing everything we can with State Board of Ed to keep kids in school. Next slide. Oh my goodness. Ventilation, improve ventilation. So increase use of fresh air, use fans and windows. Let's go to the next slide because I didn't realize how long it had gotten. So this is just a symbolism of indoor, practically for those of you that just don't think about what to do in your house. Using your ceiling fans, having your HVAC system tested, change out your filters. There's filters that have the perforation in them are better than the solid ones. CDC's website has a lot of good techniques, and I do apologize, it's 5 o'clock. And so I'll go ahead and stop here, Alex. I think I'm done anyway. I do apologize, going way too long.
That's totally okay. Judy Kauerauf, Communicable Disease Section Chief for the Illinois Department of Public Health. And yeah, that is our hour. You, just for reference, you only had one slide left anyway, so you filled the hour. Lots of great info there. Thank you for your time and your energy and helping give more information out on how we can stop the spread of COVID-19 and make better choices as we head indoors. For those of you watching who might have jumped in halfway or a quarter of the way through, the full webinar will be posted by tomorrow morning on our social media channels, on our website, shieldillinois.com, and also on our YouTube channel, which is just search for Shield Illinois. Ms. Kauerauf, thank you again. Thank you all for attending. We'll catch you at our next webinar next month. Have a great rest of your evening.